Hello students, let's study deep mycosis. In that we will see subcutaneous, systemic and opportunistic mycosis. So let's study first subcutaneous mycosis. The agent of subcutaneous mycosis usually inhabit the soil. They enter skin by traumatic inoculation with contaminated material, tend to produce granulomatous lesions in the subcutaneous tissue. So first is the mysotoma. It is chronic, slowly progressive granulomatous infection of the skin and subcutaneous tissue, also known as Madura mycosis or Madura foot, as it was first described in Madurai, South India by John Gill in 1842. Types of mysotoma and causative agents. Eumysotoma caused by fungi, that is Madurella mysotomatis. Actinomycetoma caused by bacteria, Actinomyces and Nocardia. Pathogenesis, accidental trauma, thorn prick or splinter injury. Organisms enter skin and subcutaneous tissue from contaminated soil. Microabscesses by polymorphs, chronic granulomatous tissue in skin and subcutaneous tissue. Clinical manifestations, commonest side feet, tumor-like swelling, tumification, discharging sinuses, discharge oozing from sinuses containing granules. Treatment, surgical removal of the lesion followed by antifungal agents for mycetoma, itraconazole and amphotericin B, antibiotics for actinomycetoma, amic acid plus cotrimazole. So on lab diagnosis, the specimen is collected. So granules are collected and then they are pressed between two slides and then smears are made and then the smears are stained by gram stain or HNE stain. And in the center, you can see gram positive filaments, purple in color and surrounded by the clubs of the pink material. So it is called sunray appearance. That is diagnostic of the actinomycotic mysotoma. Opportunistic mycosis caused by fungi, normally a part of human anatomical flora. Example, Candida, found in nature and frequently isolated as laboratory contaminant. Aspergillus rhizopus and the penicillium. Predisposing factors, physiological state, extremes of age, pregnancy, immune system, primary immunodeficiency, affected CMI, secondary immunodeficiency, AIDS, malignancy, chronic debilitating disease, therapeutic measures, organ transplantation, administration of broad spectrum antibacterial therapy, cytotoxic drugs, corticosteroids, immunosuppressive drugs. Other conditions, severe burn, diabetes, febrile neutropenia, zinc or iron deficiency. Opportunistic mycosis, candidiasis, Candida albicans, Cryptococcus neoformans, zygomycosis, Rhizopus mucor, Epsidia, Aspergillosis, Aspergillus flavus, Aspergillus fumigatus, Aspergillus niger, Penicillosis, Penicillium marnefi, and Pneumocystis girovesi. Candidiasis, species of Candida, Candida albicans, most common and most pathogenic. Morphology is like fungus that produces pseudohyphae. Mucosal lesions, oral thrush, bottle-fed infants and old debilitated creamy white patches appear on the tongue, buccal mucosa that leave a red oozing surface on the removal. Diaper dermatitis, elementary esophagitis, gastritis, vulvovaginal candidiasis, Candida balanitis, and balanoprostatitis. Vaginal candidiasis, perivaginal pruritus, erythema, and vaginal discharge thick divide. Other symptoms, dysuria, dyspareunia, vulvovaginal soreness. Invasive candidiasis, hematogenous or local spread, multiple or single deep organ infections, urinary tract infection, endocarditis, pericarditis, pulmonary candidiasis, septicemia, arthritis, and osteomyelitis, meningitis. Laboratory diagnosis of candidiasis, specimen skin scraping, mucosal scraping, vaginal secretion, blood, sputum, urine. Direct microscopy, gram staining, gram positive oval, budding is cells with pseudohyphae, 10% QH preparation. Culture SDA with antibiotics 25° and 37° Celsius. Colonies appear white to cream in color, smooth and pasty in 3 to 4 days. Test for identification, germ tube test, also called as Raynaud's phenomenon, Browdy phenomenon. Specific test for the Candida albicans, also called Raynaud's Browdy phenomenon. The culture of Candida species is mixed with sheep or normal serum, human serum, and incubated at 37° Celsius for 2 hours. The germ tubes are seen as long tube-like projections extending from yeast cells formed by Candida albicans and Candida dublinensis. Germ tubes, long tube-like projections extending from yeast cells, differentiated from pseudohyphae as there is no constriction at the origin. Cryptococcosis infection is acquired by inhalation of aerosolized forms of Cryptococcus neoformans. Clinical manifestations: pulmonary cryptococcosis, first and most common presentation, cryptococcal meningitis, chronic meningitis with headache, fever, sensory and motor loss, cranial nerve paralysis and loss of vision due to optic nerve involvement. Lab diagnosis: specimen CSF, blood, skin scraping. Direct detection methods: negative staining, modified India ink stain and negrosine stain, demonstrate capsule, and you can see that colorless capsule around the dark background. Gram staining, gram positive round budding is cells. Culture SDA without antibiotics, blood agar or chocolate agar, and incubated at 37 degrees Celsius. Blood inoculated in biphasic blood culture bottles. Colonies mucoid, creamy white and yeast-like. Confirmation of Cryptococcus species: Niger seed agar or bird seed agar used as a selective culture media for Cryptococcus neoformans, growth at 37 degrees Celsius and urease test positive. Mucormycosis, rhinocerebral mucormycosis, most common form: orbital cellulitis, proptosis, and vision loss. Pulmonary mucormycosis in patients with leukemia. Gastrointestinal mucormycosis, necrotizing enterocolitis. Disseminated mucormycosis, brain. Lab diagnosis: culture on SDA at 25 degrees Celsius, white, cottony, woolly colonies with tube filling growth, lid lifters. In some species, rhizopus, salt and pepper appearance. LPCB mount of colonies, broad aseptate hyaline hyphae, sporangiophore, sporangium containing numerous sporangiospores. Rhizoids, root-like growth arising from hyphae. Aspergillosis species: Aspergillus fumigatus, flavus, and niger. Clinical manifestations: pulmonary aspergillosis, most common form. Allergic bronchopulmonary aspergillosis, severe bronchial asthma, chronic cavitary pulmonary aspergillosis, extrinsic allergic alveolitis aspergilloma, fungal ball. Cerebral aspergillosis, brain abscess, hemorrhagic infarction, and meningitis. Ocular aspergillosis, keratitis, and endophthalmitis. Ear infection, otitis externa. Cutaneous aspergillosis, nail bed infection, onychomycosis, mycotoxicosis. Lab diagnosis: specimens, sputum and tissue biopsies. Direct examination: KOH 10% mount or histopathological staining of specimens, narrow septate hyaline hyphae with acute angle branching. Culture is day and incubated at 25 degrees Celsius. Species identification is done based on macroscopic and microscopic LPCB mount appearance of the colonies. Penicillosis, risk factors: immunocompromised host, transmission, inhalation of conidia, mold to yeast conversion occurs in the lungs and then yeast form spreads via blood to reticuloendothelial system. Penicillosis, endophthalmitis and endocarditis, superficial disease, osteomycosis, keratitis, onychomycosis, allergic disease, asthma, allergic pneumonitis, systemic infection, fever, weight loss, dyspnea, lymphadenopathy, hepatosplenomegaly, skin lesions, warty lesions mimicking that of molluscum contagiosum. Lab diagnosis: culture grow easily on SDA at 25 degrees Celsius. Colonies rapid growing, flat, velvety, powdery texture and greenish in color. LPCB mount of colonies: hyaline, thin septate, conidiophore with branches, elongated medules, flask-shaped phylites, originate chain of conidia, brush border appearance.
Hope you find this session useful for your understanding and for your exams. Thank you.